So we went through chapters 35 and, excuse me, I believe 40 is the two that we looked at. So some of these questions you should hopefully be able to answer as you're looking at the myocardium, and you can see what is going on right here. Plaque formation. Plaque formation is going to decrease perfusion and increase myocardial O2 demand. Okay? So if you remember, as nurses, first we talked about who's at risk. Who's at risk? Diabetics.
Women.
Obese.
Women.
Smokers. Hypertension.
Women.
Physical inactivity. And high cholesterol. By the way, what is normal cholesterol?
Below 200.
Less than 200. Okay. So what's the difference in HDL and LDL? Correct. Excellent. You learned something. Okay, so, and again, we do have non-modifiable, such as family history, age, gender, but the majority of our population, we are looking at modifiable risk factors, okay? Of course, this leads to the diagnosis of coronary artery disease, which is a huge problem in this country. Remember, we talked about two different types of situations that can occur prior to, we hope, myocardial infarction, or the actual death, necrosis of the muscle, which is irreversible. So if your patient hopefully has some type of signs, such as, what does this mean? Unstable angina. What does that mean to a nurse? Right, so we've got some symptoms at rest. This is a critical sign versus... Okay, so the patient could sit down. Oftentimes this is triggered by exertion, so oftentimes the patients will sit down. If they have nitroglycerin, they can take how much? 3. Okay, they take one every 5 minutes. If no relief after the third, call 911. Okay. So, again, these are the signs and symptoms that we're looking for. How are you going to assess this patient? What questions are you going to ask? Thank you. PQRST. What does it mean?
Pain, quality, radiation. What relieves it? Symptoms, other symptoms, and treatment.
Symptoms and treatment, exactly. Because not everyone exhibits the crushing elephant on their chest. In particular, which two populations?
Women and diabetics.
Women and diabetes. Okay, they can have other signs and symptoms. Okay. Now, as part of treatment, what can we do in the perfect world, which is NCLEX, perfect theory world, which is NCLEX. Mona, okay, so we want to do what first? Oxygen to help with the increased myocardial O2 demand. Aspirin, which does what? Decreases platelet aggregation, which is occurring as this process continues. Nitro, a dilator, vasodilator. Let's try to help open what we can, hopefully with some of these other vessels. Let's try and enhance perfusion by vasodilation. Morphine, in particular, if they continue to have pain not relieved, by the previous interventions. Morphine, again, is a great, causes vasodilation as well. So that's a good one to use and to think about. Now also, we spent time talking a lot about labs and diagnostics. What labs do you anticipate? CKMB, possibly a stress test once they're stabilized. Now there's two types of stress tests. We can put them on the treadmill, or we can give them drugs to cause an exercise state. Cardiac cath, especially if that stress test is positive. With cardiac cath, how do you prepare your patient? Assess BUN creatinine level. Why? The dye can cause more problems, okay? What else are you going to do?
Allergies.
Allergies to what?
Shellfish,
iodine, shellfish.
Kind of educated about laying flat afterwards so it bleeds.
Laying flat, so we don't initiate any type of severe bleeding or hematoma formation. Okay, and we're going to be assessing pulses, okay, at the site. Okay, so that covers labs, diagnostics. Your big nursing pieces, again, decrease cardiac output, increase myocardial O2 demand, but for the nurse, decrease perfusion. Okay, those are the big ones. Identifying who's at risk, how to assess for this, anticipate treatments, and labs. Okay? It is you at the bedside that will advocate for these patients, especially those that do not present with the more common symptoms. Okay, now that includes a lot of our basic stuff. As we move into more detailed information today, which is going to also include biggie on this exam, and that's cardiac medications. You will know them, okay? Because you will see them on boards, and again, as a nurse, you will be giving them, a lot of them, as we continue to have heart disease as the #1 killer in this country for men and women, and the population ages. You're going to see more and more of this. Okay, so essentially what have I done is I, of course, have read my chapter in detail, and in my mind, this is chapter 37 without the meds and the diagnostics. Again, for my nursing students, I'm very strong in believing what is actually happening in the body. Once you manage that, then you can understand the signs and symptoms you see, as well as understand why you're giving the medications that you're giving. Okay? So today, we're moving to chapter 37. This chapter includes the #1 DRG diagnosis in this country, which is now called heart failure. It used to be called congestive heart failure. It's still being referred to that. But people don't understand you can actually have heart failure without excess fluid. Not the typical, but it truly can happen. So essentially, you'll think of now the heart fails. We're not going to the infarct state, to the shock state. That's coming in 213. So this provides you with a strong foundation that you're going to need in 213. so basically we're going back to some of our physiology, okay, that can be hard for students, but once you keep at it and keep ingraining it in your mind, it will click. Because it all ties into decreased cardiac output, increased myocardial O2 demand. Okay? So what I've done is I have taken the words in the chapter and put it in a visual format, because for me that is how I learn things. So we know initially the heart rate will rise in response to the decreased perfusion. Okay? Why? You have to remember the sympathetic nervous system is going to kick in to this response. Initially, your blood pressure will rise in response to the increased release of norepinephrine. Okay? Because, again, the body is not getting what it needs in regards to perfusion. So, what happens? If you remember, we talked about preload and afterload. So in other words, the pressures, this is it, for those of you who work with hearts, these are the actual pressures that can be visualized. They have to be obtained by a monitor, and I don't want you to know that right now, it's just in my mind, that's how I see it. It's just these pressures rise in response to the decreased perfusion and increased demand. So the pressures are rising, the resistance is rising. So essentially, the heart's working harder and harder to meet the body's needs. This is a normal compensatory response. Okay? The problem is 3/4 of the Americans don't have a very good myocardium. Okay, so that makes it even more problematic. So remember, this is what we spent time talking about last week. So we're going back to that, now going into a disease process. You have to remember, though, it's not just the myocardium that's being affected. It's the one working to meet these demands. When you have decreased perfusion to the brain, guys, it sends out a message to the pituitary to release antidiuretic hormone, also called vasopressin. Now, if you've ever been in a code situation, some of you would know that you can give vasopressin one time in a cardiac arrest. Normally, the drug of choice is epinephrine, okay? But this is the brain's response to this decrease in perfusion, okay? It also is telling the systolic pressure to rise. Okay, so that's not helping the heart either. But the brain demands perfusion. Okay, so antidiuretic hormone, vasopressin, is what's being released. Now you tell me, nurses, antidiuretic hormone is doing what to the body? Hold on to fluid. Okay, so the heart can pump harder and harder and harder. Okay? So that's what it's telling the body to do. Now, last week, we talked about decreased cardiac output or blood flow to the kidneys. What does RAAS mean?
Renin, aldosterone, angiotensin.
Nice words. What does it mean to the nurse?
Decrease. We'll release those.
You got decreased perfusion to the kidneys, and what is that mechanism doing to the body? Angiotensin 2 is a potent vasoconstrictor. So it's saying clamp. You remember last week I said, don't care about your feet right now. We don't care about your arms anymore. We don't care. Constrict. Now, aldosterone does what? Sodium and water retention. Again, hold on to that fluid. Where there's salt, there's water. Pull it in so the heart can pump harder and harder and harder. Okay? So this cycle continues. Now I want you to imagine your little 80-year-old who's already had an MI and hypertension, coronary artery disease, and a smoke. Well, eventually, this ain't going to keep going, okay? And what's going to happen, the heart will fail. Now, you remember what I said? It's not going to stop pumping. It will pump until it can pump no more. But the body starts trying to do something with all this fluid. Well, the body is having a difficult time with all this fluid. And in essence, the compensatory process is making the situation worse in a compromised myocardium. Now, when you look at heart failure, the book, theoretically, they divide it left and right. That is to help the student to understand the mechanisms that are occurring, okay? Now, truthfully, the majority of patients will develop left heart failure. Why? Because it's the big pumping mechanism. That, in turn, leads to right heart failure. Solely in situations, in patients that have like pulmonary hypertension or smoking without any other cardiac problems, will you see the reverse. Generally, rule of thumb, left heart side failure starts and progresses to right side failure. Why? Because this is the big pump. Okay? And as this process continues and the heart works harder and harder, again, the heart fails. Doesn't mean it's quits pumping. Okay? It could. Okay? But we're not going there yet. Okay? We're not going to MI and arrest and all that. We'll do that in 213. So, if you think about the plumbing, okay, so all that fluid, because you don't have, like I try to teach students, when you don't have that blood, I refer to the blood as like the meat and potatoes, right? It's what just holds everything together, okay? So, when you don't have that pressure that's generated by that blood, then that pressure drops and your hydrostatic pressure says it's now higher. So what does the fluid do? It moves over the little pulmonary vasculature, and now all of a sudden your alveoli are trying to swim in fluid. Because of changes in the pressures, the fluid seeps into the pulmonary vasculature, okay? So that's when you start having, and it gets wetter and wetter, and the crackles start, because of gravity and pressure, the crackles start here, and where do they go? They move up in the body, okay? Patients short of breath. Yesterday, they got upstairs to their bedroom. Today, can't make it upstairs to the bedroom. They're so short of breath. Okay? Some of them even now start, if you ask them, they're like, yeah, I wake up at night and I get short of breath. How many pillows are you using? Instead of 1, it's now 2. You're using 3 pillows now? Because I get short of breath. Okay? So, what started out as a cough progressed to shortness of breath. can't sleep at night. So I just increase the number of my pillows, and now I have crackles. Okay. If you were to auscultate, you could potentially hear what is called an S3. An S3 is a gallop. Okay? It's because of the fluid within the myocardium. Okay? So you're having an extra sound on diastolic filling because the heart cannot pump effectively. So these are some of your cardinal signs with left-sided heart failure. Okay? Y'all are looking at me like deer to me. See, it's when I go to those pressures, isn't it, that you lose me. What holds your fluid in? Does anybody really know what holds your fluid in? That's your pressures, guys. It's called it's your proteins, and your albumins make up colloidal pressure. That pressure is high. And because it's higher than the interstitial pressure, when you take in all those fluids, it stays within your body, and the vascular system sends it to the kidneys, and it's eliminated. Okay? Well, you don't have that process going on. So fluid now doesn't stay where it's supposed to stay. That high pressure system is now a lower pressure system. Right? Because you don't have the blood flow. And because of that, this pressure becomes higher. So the fluid goes, when fluid goes into your pulmonary vasculature, you're in trouble, okay? You're going to hear the crackles, your little alveoli are swimming, and that leads to the almighty. So if this person doesn't get help, and yes, we're going to the drugs, this person doesn't get help and get rid of some of that fluid, and Lord help you, you hope their kidneys are not fried, that their kidneys still work. Otherwise, patients can drown in their own fluid. They'll develop what is called flash pulmonary edema. The sputum is so thick, it has a pinkish tinge, and this goes down the tubes. And then in 213, you're going to learn how they go into shock, and we're going to put them on a ventilator, and you're going to hope they make it. So this is left-sided heart failure. Okay? So as you then, over time, age, myocardial issues, over time, then it leads to this. Now all of a sudden, your feet swell. Because why? Well, this pressure keeps rising. This pressure keeps rising. The heart works harder and harder unless you get some major medications on board. And so now the plumbing backs up to the periphery. So now your feet are swollen. You can have venous distension, jugular venous distension. Your liver can become compromised. You can develop fluid pretty much anywhere in your body. Ascites, in the sacral area, in the scrotum. So now, you're just one big fluid-filled blimp. Because, again, this pressure that should hold the fluid in is now going where? Pretty much anywhere it can go. So that's why the majority of your patients, you have coughing, crackles, and your feet are swollen. You're in trouble. Now don't get me wrong, because of technology and because of medication therapy, these patients live long lives. But they are in and out of the hospital, thus the #1 DRG diagnosis in this country, costing billions of dollars. Okay? How many people know someone in heart failure? I'm sure most everybody does. Yeah. And again, you're going to see it more and more and more. So again, as that heart fails, generally this leading to this. So as a nurse, you need to learn to anticipate signs and symptoms. Anticipate who's at risk. That ties back to all of this, okay? And then this takes it to a higher level of understanding, okay? So based on what you already know, what might your treatment be?
Elevated?
Yeah.
Okay, fluid restriction. Somebody said Lasix. What type of bed is Lasix?
Diuretic.
Loop diuretics. So it's going to get rid of the sodium and potassium. And based on what you learned last week, a low potassium
That's going to affect the heart.
can affect the rhythm of the heart, and that's going to create even a more serious problem. So as a nurse, it is up to you to make sure labs are being drawn, because if my second-year students, you know, the doctor will order it. The doctor will order it. On neuro, I can't tell you how many times we've turned around to give heparin or something, and somebody hadn't ordered a dang platelet in 5 days. So, I'm just saying, I don't care where you work. It is up to you and your brain to make sure this patient gets the care they deserve. And by understanding what is going on, you learn to anticipate what needs to be done.
So in this case,
Not immediately. Okay, first, and I know we're going to need a break, but I'm trying to cover just a few meds here. I know, it's so hard this morning. Aldactone is actually a very weak diuretic, so that would be later on, Jeff, to answer your question. Immediately, what? Oxygen?
Head a bed up.
Head a bed up. You need to teach this person ways to enhance breathing. What might you do to the feet? Elevate them above the level of the heart to enhance venous return. You're helping the heart, okay, to decrease that myocardial O2 demand. Okay? We could give them a vasodilator. In particular, if their pressures, we know their pressures are high, right? So even if they don't have pain, we might give them something like, what vasodilator have you learned? Nitroglycerin. But you better be careful, because what else? The diuretic's going to do what? It's going to decrease blood pressure too. So you've got to be very, very careful. And 9 times out of 10, if the patient's compromised, the physician's going to order that Lasix IV push, right? Okay, so you're probably going to give IV push, maybe 40 milligrams or 60 milligrams IV push. And as I always tell my senior students, make sure you're monitoring PP. Okay, so I don't want to walk in there and see a Foley bag full. We need to evaluate this response. Know your labs. Stay on top of your blood pressures because we want to enhance their outcome. Okay, so we want them, your outcomes would be what? Especially in regards to this. Okay, no confusion, right? Okay, perfusion. You guys know how to check perfusion. You never get away from basic 101. So you're assessing perfusion, listening to heart sounds, lung sounds, okay? I's and O's. All of this becomes very, very critical for this patient, okay? The big thing is we got to get them to breathe, hopefully non-labored, within a so-called normal rate. These patients' respiratory rates can get above 24 just because of the fluid. And not just the fluid, but this. Now you guys know, you already got myocardial O2 demand increase. Now you don't have adequate gas exchange. So you can see how if somebody can crump real fast, okay, if they don't get to the hospital and get treated for this. And like I said, you better hope their kidneys work, or you're in a rock in a hard place. So essentially, what we're going to do after the break, since I'm over taxing your brains, is we're going to look at a lot of the medications. Okay, so I'm going to talk about that, and then we'll be looking at the PowerPoints. I have a case. I'll let you, so I'm not standing up here running my mouth all the time. You can apply, see what knowledge you can apply. We'll finish up with hypertension. I put that in today because that ties in more with pharmacology. Okay. Also remember, we'll do test review. So if you want to participate in that will be today as well. Okay? So go ahead and take a break. We could look at the size of the ventricles and the valves and get kind of an idea of what's going on there. Okay? But again, a lot of our patients, we look at histories, signs and symptoms, and again, they're in and out of the hospitals. This is why now you're seeing, we actually have congestive heart failure clinics that our patients can go to for follow-up. We even have patients in the hospital that would come in at Maine, and they would actually have like drips running to help with the pumping of their heart. So there's a lot being done in the outpatient setting trying to prevent readmission, but it is still the number one admitting diagnosis. Okay. Also, I want you to make sure you're always thinking about weight. Weight is more accurate than I's and O's. You want to educate your patient to weigh daily at the same time to get a better idea of weight gain. Okay. If a patient gains 1 to 2 pounds in 24 hours or 4 to 7 pounds within 4 to 5 days, then that's a red flag that you've got too much fluid. 1 liter of fluid is 2.2 kilos or 1 pound. So it's very easy for them to accumulate fluid, and you will see that in the weight. So they should be on top of weighing themselves every day. That can actually help prevent them from having to be readmitted. Diet, of course, very, very important. Most of our patients are on a 2-gram sodium. Some 2 to 3 grams would be the limit. And if you assess your sodium intake, in a day, you would find that to intake 2 grams is not that hard at all. So we encourage our patients to limit sodium. Make sure that, I'll go ahead and say this, when we start talking about your ACE inhibitors and your ARBs, okay, remember they inhibit RAAS. So sodium does what? What happens to the sodium when you take an ACE or an ARB? It's an analysis question. Come on, what does it do? If you block it.
It lets it go. Well, yeah, you would get rid of it.
We're going to have to spend time.
Yeah.
Okay. Okay, right now let's just keep it at the 2 to 3 gram. Weigh daily. Okay, some of our patients are on fluid restrictions. A lot of them don't follow it. Okay, but a lot of them are good about weighing and try to watch their sodium intake. Okay. So when you start looking at the meds, okay, if you tie into what's happening in the body, I'll start with number 1. Renin, angiotensin, remember? It's a potent vasoconstrictor, aldosterone. This is a normal compensatory response to decrease cardiac output. In particular, blood flow to the kidneys. Renin's released, it's causing vasoconstriction and hold on to sodium and water. So one of the big drugs we're going to want our patients on after the obvious oxygen is an ACE inhibitor, okay, and now I'm trying to focus on more long-term right now. ACE inhibitor and an ARB, or angiotensin 2 reverse blocker. So if you block the conversion of 1 to 2, or if you block 2, what then happens? Okay, you're going to get some dilation because you don't have that, the work of the angiotensin 1 and 2 causing vasoconstriction. And what's happening to fluid? Okay, so you're not holding on to sodium and water. Analytical question, what happens to potassium?
Potassium follows.
Rise. You lose sodium and water. What happens to potassium? Right, so sodium can increase. You must educate them to not use salt substitutes. Because what is in a salt substitute? Potassium. So our patients on ACE inhibitors and ARBs have adequate or potential for higher potassium. Okay, so we're blocking that effect. The angiotensin 1 and 2, we're blocking the vasoconstriction, we're blocking the aldosterone effect to hold on to sodium and water, so therefore we got dilation, we've got loss of fluid and sodium, but we can hold on to potassium. They should not use salt substitutes. They need to stick with a 2 to 3 gram sodium diet. Okay? That's an analytical question. I guarantee you're going to see it again, okay? Because it's a good question. It's one you can see on boards. Do you understand the mechanisms? So these are two biggies. These have been shown to reduce morbidity and mortality in the heart failure patient. These actually work very well in our African American population. Okay, but remember what I said. Most patients are tried on an ACE inhibitor. Okay, if they have side effects such as that nagging cough, then they will prescribe the ARB. Remember, this is more expensive, but so usually this one is prescribed. Our African Americans are at higher risk for another side effect of these meds, and that is angioedema. Just to let you know, there is one out there, as Renee reminded me. She was like, did you put renin inhibitor? Well, I didn't include renin inhibitor in the farm slides because I never see it. And, well, and of course, you know, Ms. Hyde, it's $12 a pill. And I said, oh, no wonder I don't see it. But there is one renin inhibitor. You can figure it out. So it blocks here and prevents the whole process, and that is Tecturna. It is the only renin inhibitor out there at this time. I do not see it in the hospital. But you have to see it. Also, again, we need to give diuretics. That is another must. Okay? So, in the initial state, in the acute state, if they're in the hospital, we would give a loop diuretic such as Lasix, okay, because it works very quickly. Again, you're going to lose sodium in water, so you must monitor, which is why I put replacements here, in particular potassium, magnesium. You've already learned about the conduction system, so you know that these being low can impact the rhythm and make this whole situation worse as far as perfusion. Okay? So that would be initial. It's up to the physician whether they want to continue with Lasix by mouth. A lot of them do because it's an old drug, it's cheap, and it works very effectively. Okay? There's other ones out there, and that's called your thiazide diuretics. Not as effective, but they work very well in combination with like an ACE inhibitor. That would be like your hydrochlorothiazide. Okay? And if you remember, your ACE inhibitors are, what's an example? Your Prils. Your ARBs are your sartans, like losartan. Cozar is an example. So if you remember Prils and sartans. Very, very important with a patient with this diagnosis. Okay, so essentially we're trying to stop some of this process, challenge the kidneys to help enhance perfusion and decrease O2 demand. Okay? Another way to what is considered to protect the myocardium, again, because of the increase, if you'll think of it, increased workload of the myocardium, resulting in the decreased perfusion, increased oxygen need, we will sometimes give beta blockers, okay? Oftentimes now we give what is called selective beta adrenergic blockers. They block beta 1 and beta, in particular beta 1, less on beta 2. And this would be like your toprol, okay, metoprolol. These are your old laws. And it's interesting to me, a lot of my first year students don't understand. They're like, well, you're slowing the heart rate and you're decreasing the pressure. How is that working to do this? Well, if you understand this, then you understand this. So in a normal heart, so you got a normal heart. You take a beta blocker. Yeah, she's at risk for lowering her blood pressure and her heart rate and being symptomatic. But in a heart that has decreased perfusion, increased myocardial demand, from whether that be an infarct, CAD, or whatever, you have got to decrease the workload. Okay? And I don't care how you go about doing it. If that patient's heart rate is 120, you better lower that rate, or that heart is going to fail even more, okay? So a beta blocker can be used for that purpose, okay? Another way to lower rate, you can also give these IV push if it's needed in the immediate setting. Okay, we gave, like metoprolol can be given IV push, labetalol can be given IV push. Another drug that you could give, in particular if the rate is high, is your calcium channel blockers, such as diltiazem. Diltiazem can be given IV, verapamil can be given IV. Those are drugs in particular that really help with rate, okay? So, beta blockades, protecting the myocardium, calcium channel blockers. This is why, guys, once you understand all this, this is why your patient's on an ACE inhibitor, a beta blocker, a calcium channel blocker, and potassium, and Lasix. And that's why they're on to protect the heart muscle as much as we can, okay? Other medications that may be used, your nitrates or your dilators, okay? Nitrates, Emdur is one, Isordil is still out there, of course, nitroglycerin, IV, or sublingual. These, again, help protect the myocardium and decrease that workload that is taxing this patient, okay? Okay, another class would be your inotropes, or one, this is also listed as cardiac glycoside. A glycoside is a positive. It causes increased contractility. The one that you are most familiar with is, of course, digoxin. Digoxin can be given IV or by mouth, okay? A little problem with digoxin, which is what? Toxicity. So your patients can actually lower their heart rate to the point that that compromises the myocardium, okay? So Dig is a great drug. It's an old drug. It's been around forever, and it's, again, helps to enhance contractility, all right? Ones that are newer now in the acute setting, even in the outpatient setting, is IV dobutamine. Okay, dobutamine is a beta-adrenergic. It actually enhances contractility and is used quite a bit. This one is another one. It's listed in your book. It's milrinone. That's another one, or Primacor. And then the one in a class by itself is IV. This essentially is IV BNP, a synthetic form of BNP, and that's called Natricor. Natricor will vasodilate and enhance output, therefore enhancing perfusion, and decrease in myocardial workload. It's actually a synthetic form of BNP. Synthetic form of BNP, Natricore. So truly, for most of you, if you're out on the hospital floors or whatever, majority of you are going to see oxygen, your ACE and your ARBs, your diuretics, your replacements, your beta blockers, I forgot to put calcium channel blockers, possibly your nitrates, possibly your cardiac glycoside, and one more. We always say, next week we'll start out with you are clogged from your head to your toe. And that is your central alpha agonist, which blocks this. We're reversing this now. This reuptake of norepinephrine, we're going to block that. And that's going to help with our resistance. And that, the most common, most of you have probably given it, is called clonidine. Clonidine, okay? So it's a central alpha agonist, okay? That's to help lower that resistance, okay? There are others out there, but I'm not going there until 213. So again, this is why your patient right here is on a breakfast of pills in the morning, okay? And it's very, very important. Like I was telling my group last week, you need to try to stick with that rule of if their blood pressure is less than 95 systolic, or if their heart rate's less than 55, then caution. But just because their numbers are low, you guys have got to use your minds and look at trends and realize that if we keep holding these, you're hurting that patient. You are hurting that patient by doing that. And in other words, what I always say is you're treating a number. You're not treating the body, the heart. So that's why I'm adamant about understanding information. Okay? A good reference for you guys, I was looking where to find, like a chart, is page 781. You'll see a lot of these listed. Okay? Okay, do you have questions about those medications? No? What I'm going to do now is, instead of listening to me, 775 to 785. Long-standing chronic hypertension is a big reason for congestive heart failure. Okay? That and coronary artery disease. Those are your biggies that lead to failure of the heart. So basically, what you will see on the slides is a lot of information. There are some stats that you can look at. They do have classes. This is by the American College of Cardiology. They class stage A through D. There is also the New York guidelines, which is stage 1 through 4, I believe. But just to give you an idea of how they class heart failure, again, you can see tons of people in this country who are at risk, and the numbers are high, basically, and then it goes down to the advanced stage. And I'm pretty sure both are listed in the New York class and the American College of Cardiology. So the stats are high. Like I said, it is costing healthcare billions and billions of dollars. The book talks about this. To me, as a nurse, heart failure is heart failure. You need to to understand the physiology that we just talked about in order to understand why you're treating what you're treating, as well as anticipating the labs, the signs and symptoms, and advocating for this patient. So I would not really go there, but that is in the book. The easiest way for you guys to learn is probably how we divided it up, knowing the signs and symptoms of left side heart failure. Why? Because that is generally, rule of thumb, where heart failure is going to start, because that's the big hump. Then progresses to right side. But these, again, are your signs and symptoms that we've talked about. There are a couple little pictures that may help some of my visual learners, and those are there as well if you want to look at that. Here it is, the New York classification. Okay, again, we spent a lot of time talking about meds. And so pretty much the things that we went over are things that you need to be aware of when the patients are on some of these meds. And now you should understand why, based on what's happening in the body. This is Inotropes. Again, I remember when it came out. It is a synthetic form of BMP, and it does cause vasodilation and diuresing. So, okay, who's at risk? Your signs and symptoms. PE is physical exam. Signs and symptoms. Talked about weight. You guys know this is a thorough head-to-toe cardiovascular, respiratory, very multi-system assessment. Okay, you should, as a senior student, already know signs of fluid overload. We talked about fluid restriction and, of course, diet and weight. This is just an old slide, but sometimes it can help students in understanding measures to take. Probably that one we don't use much anymore, but the others are still appropriate as far as, it's just a mnemonic. That's really all that is. I think there's one in the book too. So, as a nurse, okay, we talked about anxiety, we talked about enhancing breathing, enhanced perfusion. So, you need to keep in the back of your mind that, you know, what kind of activity is appropriate for this patient, because everyone wants to get up and do for themselves, most patients. And you have to teach them what is appropriate activity. Okay? So when my congestive heart failure patient first gets out of bed, I stay there. I don't delegate that to a CNA, because I need to make sure, for example, if they need oxygen, and that their breathing is not compromised by that activity. So you need to keep that in mind. Fluid volume, anxiety, again, those are a lot of things. Referrals. Please get referrals. Nutrition, case manager. A lot, well, I won't say a lot, but there are a lot of patients in hospice care for end-stage heart failure, just like end-stage renal disease. Eventually the systems fail, and then that's when we actually had a patient last week. We give like morphine every hour. We give atropine to drop secretions to help keep them from being in a labor breathing situation, because they're essentially drowning in their own breathing. Okay, so you will see these patients in end-of-life care. Okay, what happens, again, if you are a dodo nurse and you're running fluids at 150 an hour, you know, because this patient's not peeing and you think they're dehydrated because you don't know anything. You can actually put them into what is called flash pulmonary edema. You are actually causing them to drown in their fluids, okay? So that is why your continuous ongoing assessments are so important. Your patients can certainly come into the emergency department as well in flash pulmonary edema. This is an emergency situation. Oftentimes, if measures such as oxygen and diuretic therapy and drips are not working, then we will put them on a ventilator to get their situation stable. And yes, the heart can fail to the point you can go into shock. So, again, very, very important to not let this happen. Okay, so here's a patient. Again, she wakes her husband. Notice what she's doing. She's up now on her 3 pillows. He's had it. And that is often the case. The person living with them has had it. And they have watched them continually have increase in breathing problems. So they get to the hospital, and you can see we've got the increased heart rate, and notice it's irregular. Not breathing well at all. So what are you going to do? Oxygen would be wise. What position? Okay. How about a monitor? Okay. Get an IV started. IV access. Okay. Continuously monitor that and get your orders, such as morphine. Better watch that blood pressure. You're giving that morphine, especially if the physician orders nitroglycerin, and I would definitely want that nitroglycerin on board. And treating the atrial fibrillation or that rate. Okay, so we talked about your beta blockers, we talked about your calcium channel blockers, and lower that rate. Okay. His physical exam, you anticipate those crackles. He's got an S3, and you can see he's got what? He's got right side involvement as well. Okay, so you have left and right heart failure. You can see he's had anterior wall, guys, is the left side of the heart. So he's had an infarct to the left side of the heart, and he's got family history. So I'm hoping I don't need to reiterate this. Is everybody getting a handle on this? Or maybe by going home and studying why the fluid is building up. Okay. What orders do you want? Labs. I want my labs. I want my B&P. Okay, and hopefully that's going to be a stat. Okay, and then hopefully I can get some IV push Lasix and maybe some other drips started. And we've pretty much gone over how to evaluate. We want decrease labored breathing, increase perfusion. Those are your biggies. Okay, and I've skipped that for next week. This is the one, 775 to 85, 785 in your book. Why is this, again, one of the number one reasons that heart failure is such an issue is because it is a silent killer. There are tons of people walking around with hypertension and do not know they have it. Okay? Oftentimes, it's not until they get to like a stage 2 to where symptoms can start occurring, such as the headache, the dizziness, I don't feel well, I'm fatigued, I can't, I mean, some people can even have pain, chest pain. I have swelling in my feet, I just feel puffy. So again, it's often not until the hypertension is in the stage 2 criteria that, again, the symptoms occur. Okay, hypertension is the #1 risk factor for stroke. So this is why it's a silent killer. And by the time they get treated, then a lot of the damage is done. Primary is the #1 reason for hypertension. There's a lot of factors that go into that, but the exact cause is truly unknown. Okay. We do know all those things that we have talked about, such as taking care of yourself, getting physical activity, eating right, not intaking so much sodium, no diabetes. A lot of those factors play into this. Secondary is exactly, you often see secondary hypertension with like your renal issues. This is actually a tumor of the adrenal medulla that can cause hypertension. So there's other reasons for secondary hypertension. The majority of our patients, it's primary. Okay. The big thing about hypertension is identifying it early and treatment. Okay. And this will go back to all of those meds that we have discussed, and that's generally what students have to spend time with in learning. Okay, so we went over a lot of this information as well as education. Does anybody in here have hypertension? I'm just curious, what symptoms did you have, or did you? Headache. Headache and spots. So something that you could contribute to fatigue, or so again, often goes undiagnosed. I didn't spend a lot of time talking about this, but again, you guys should know with all these medications there are cycles. Beta blockers, I will tell you, one big problem with beta blockers is it decreases libido. And I have had serious problems with it. Especially me, not beta. So it does. Calcium channel blockers, ACE inhibitors, a big one you call. Really with education, I would mention to you as nurses, a lot of these medications, as you and I know, lower blood pressure, and it takes some time to get them in your system. Please teach them, as we talk about high blood pressure, teach them about orthostatic hypotension. I mean, people can fall in the floor and break something because they don't think about, all of a sudden I'm taking this medicine now, so, I can just get up out of bed like I normally do. And that's not the case. So they need to sit up on the side of the bed because these meds are controlling heart rate and blood pressure. They need to get up on the side of the bed, sit there, and then get up because of orthostatic problems. So those are part of your responsibilities. That's a mnemonic you may find helpful, but it's little things to remember. Full head to toe. Don't take this for granted. They may say, oh, I just have a headache, nothing big. But hypertension, more than 2 episodes of diagnosed high blood pressure. You should be diagnosed with hypertension. Okay? Why? You can see the stages now, right? So here is great. Here we educate. Here you may buy a med. Oh, you're definitely buying a med. Probably more than one. Okay? So again, if you have 2 documented pressures that are elevated, so you could fall into stage 1 or stage 2, you have got hypertension. Okay? I'm not talking about the patient who goes to the doctor and their blood pressure rises, but then when they get back home, it goes back down. Okay? This is, no matter what, the pressure is high. So, not taking symptoms for granted. We've talked about the history. We've looked at all the stuff we need to be asking our patients. Okay? This ties in with dietary, decreased sodium, and probably low cholesterol. Okay? And that can be very, very difficult diet for patients to adhere to. And then you turn around and tell them, well, you really should limit your caffeine. I mean, they're just like, crazy lady, you know? I don't think so. And again, because we have to educate them, we're trying to protect their heart. Okay, so decreasing cholesterol, looking at lower sodium. Not using salt at the table can be a huge accomplishment for some patients. I mean, huge. So a lot of these things have to be taught and reinforced. And I will tell you, you guys already know from psych, who is going to be successful? The ones that have support, the ones that are truly serious about this, and they work together to make it happen. Okay? Because this is not an easy diet to adhere to. We talked about weighing and taking meds. And of course, you know me, I always have your patient in here. But again, before we do the review, this is your patient, very young. He has a headache. He finally goes because somebody's tired of hearing him complain. Okay? And unfortunately, we have a major problem here. What stage is that? This is a problem, okay? This is probably a patient that I would say, okay, you know, your blood pressure's high. I'm just going to let you sit here a minute, and I'll come back in maybe 10 minutes and check it again, okay? And I'm going to check it in both arms because I need to identify we got a problem here. Not only that, I found out this patient has a family history. Okay, so I'm not sending you anywhere. So let's say I check it again. His pressure's high. Okay, the physician actually prescribes. This is a combination. Does everybody see that? A thiazide and an ACE inhibitor. So we're prescribing a medication. So as a nurse, you have certain things to teach, and I've covered all of them. Okay? So there are things now you will need to educate him about and making sure he knows how to follow up. Yes, you can buy a pretty cheap blood pressure cuff at CVS that doesn't cost you an arm and a leg. And the big thing I tell my patients is this: it's not just one reading. You take it at the same time every day, and I want to see your readings when you come back, okay? To know that tells me you're taking your medicine, you're complying with what you're supposed to be doing, and the blood pressure's coming down. So this patient will probably want a 3-month follow-up. Questions about that? Okay, a lot of material.